Thank you so much, Shweta, and it's my pleasure to be speaking in this important session. And the topic given to me for today's lecture is on painless PRK. So it's an interesting topic because PRK is synonymous with pain. And we've all those who do refractive surgery over the years, we've always understood that pain is an integral part of any kind of surface ablations. Photorefractive keratectomy, when it was the first procedure that was started, and in fact one of the main reasons why it never became popular in the 90s was the haze and the pain and the inflammation which used to happen, and patients would be struggling, patched up in both eyes, and sometimes for 3-4 days till the epithelium healed. So there's been a huge advancement ever since, and today it is actually possible to do a PRK without experiencing any significant discomfort, thanks to newer technology and lots of new things that we've been able to do. And I'll be talking to you about those few things that can be done. So going on, we've had refractive surgery evolve in the last 25-30 years, that we've had excimer lasers from the most initial PRKs that we used to do with epithelium scraped off, alcohol assisted removal of the epithelium. And PRK was done for high corrections. I do have some patients in follow-up who were operated in the 90s in Amritsar and a few other places for as much as 20 diopters, and they are very happy patients, some of them reading 6.6, because they used to use very small optical zones. But because our understanding of PRK at that time was not great, so PRK never became very popular, and within a few years we found the benefits of LASEK. Till we went overboard doing LASEK for all our patients, till we realized the risk of ectasia, because nobody realized that weakening the cornea with LASEK to the extent of more than 50% would lead to ectasia. So then we started again taking the back seat. Everybody was scared of doing LASIK, and then we evolved to LASEK, which was a modified form. Nobody wanted to go back to PRK of the old, and so a lot of development took place, and we started doing LASEK, we started doing epi-LASIK, we started finding out lots of other ways of advanced surface ablation. So it has evolved a long way, and today we are on a form of advanced surface ablation which is even more advanced than what it was 5-7 years back. And then of course the other way we evolved was into the femtolasic, and we all became conscious of the residual bed and the benefits of thin flaps. And today we are doing flapless surgery with SMILE, which has again given a lot of benefit. So today I think the two most popular surgeries would be a flapless surgery like a SMILE. In my practice, in fact, now femtolasic comes at number 3 and microkeratomy comes last. So we do SMILE and we do a lot of surface ablation, and we do very few flap-based procedures now. So talking about PRK procedures, there are various ways to bell the cat. You can do alcohol-assisted PRK. You can do LASEK, which is laser epithelial keratomileusis. You can do the epipolis, laser in situ keratomileusis, the epi-LASIK. You could do the transepithelial PRK, which is very popular today. I'd like to do a lot of transepithelial PRK. So there is renewed interest in corneal surface ablation due to the lower risk of ectasia. In fact, biomechanically, the eye cornea is strongest with PRK, even stronger than what you might get with SMILE, even though not too many studies are still available. And there are almost there's no risk of corneal flap complications when compared with LASIK. Of course, that small chance of having corneal other problems with PRK which are unique to PRK, like the haze and more possibility of getting infectious keratitis. They are rare if you do them right, but you have to obviously be a little more careful when you do a surface procedure as compared to LASIK regarding this. So the advantages of PRK and LASIK, as we already discussed: no flap complications, faster recovery of the corneal nerves, which minimizes the amount of dryness. So dry eye in surface and SMILE is seen much less than is seen with any kind of LASIK, including microkeratome and flap and femtolasic. There is the extra margin of safety in patients with thin and borderline or steep and flat corneas. So if you're having a steep or a flat cornea, you would not want to use a microkeratome on those eyes, nor would you like to make a flap in a very, very steep cornea, because that could compromise the strength of the cornea. It could be a potentially suspect cornea. And even though the topography may be perfect on steep corneas, I sometimes try to move towards the surface. And again, if you have borderline thickness corneas, you would probably not want to disturb them by weakening them further with making a flap. So either I would do a SMILE or a surface. Again, SMILE, the parameters remain almost the same as those I do for LASIK. So there's almost no difference between my exclusion criteria for LASIK and SMILE as far as corneal thickness goes. However, on thinner corneas, I don't hesitate doing a small surface ablation if the topography and everything else is perfectly fine. So the preferred procedure for professional athletes who incur risk for physical contact, even a lot of people who join the forces and those people who do not want any kind of scar on the cornea from any kind of surgery, so they don't want surgery to be detected if they're appearing for a medical exam, they all would be ideal candidates for getting a surface ablation procedure. Now, the best part about surface procedures is that ectasia is extremely rare. There are just only very few reports of ectasia following a surface ablation. Of course, it is entirely possible, which is also possible in a normal untouched eye, but then PRK-induced ectasia is not very often seen. So that's a big advantage. So all the reasons why you can start doing PRK, and of course it also cuts down on the cost, because all you are going to use is an excimer laser. You don't need to invest in a microkeratome. You don't need to invest into a femtosecond laser. You don't need to invest into a Visumax for a smile. And eximers can be very easily available, and there are a lot of surgeons now who restrict themselves to just surface ablation completely, and that's because we have these newer techniques which allow us to do that. Now, following PRK, there are limitations, and we all know them, but I would like to highlight them once again. Mild to severe eye discomfort, maybe in the first couple of days, has been the most common problem that PRK patients have faced, and doctors are very wary of. I know of a lot of my colleagues who are prolific refractive surgeons. Somehow they just don't like to do surface ablation procedures for the fear that the patient is going to come back and complain next morning, and for the first few days that I was very uncomfortable. Longer period for visual recovery. As compared to LASEK, there will be obviously a longer visual recovery period because the epithelium is disturbed. So till the epithelium grows back, and even much after that, because epithelial remodeling continues for a very long time. So it can take a week or two for patients to become comfortable for their vision, and can take up to a month for them to be crisp, 6x6, or even 3 months. But 90% of patients within a week are functionally good. So by the time I remove the contact lens on the third, fourth, or fifth day, patients are already seeing fairly like 6/9. Even on day one, actually, so many of them are reading 6/6 now with the new protocol that I'm following, but let's come to that later. Haze has been tackled very well with the pioneering work of Parag Majmudar and Randy Epstein. Their protocols, which I started following almost 20 years back, with 0.02% for 12 seconds, and longer if you are doing some extreme cases, has worked very well for us, and we hardly see haze. And of course, there's more to it than mitomycin, and I'll discuss that. Regression, which was one of the common things when we started doing PRK right in the beginning, was more related to the excimer ablation pattern which we were using, and we now don't see those anymore with the newer flying spot lasers with their optimized profile. So regression has been tackled really well, and now we don't hesitate, or we don't even change our nomograms when doing surface ablations as compared to LASIK ablations. So what is the current status of PRK? PRK, we all understand that now, as I said, haze is now extremely rare. The refractive stability is excellent, and I would not hesitate to offer this to patients who were looking for crisp 6x6 vision. You just have to tell them to be a little patient with the visual recovery. So what holds us back from doing more PRK? Why aren't we doing a lot more PRK than we were doing in the past? So I think in the discomfort that patients feel, since everything else is more or less kind of sorted, why are surgeons still uncomfortable offering PRK as the first choice to their patients? This has really changed in the last 2-3 years. So maybe my slide is not in order today as much as it was maybe a year or two back, before we started doing the pain control methods, which are so much more controlled now. So the pathophysiology of the subtypes of corneal pain could be inflammatory, nociceptive, neuropathic, and many things have been tried. We've had pharmacological interventions with topical opiates, 0.5% morphine, topical anesthetics like proparacaine. So Postop in the US, this was practiced quite often, and some surgeons even in India have practiced this. They used to give drops to the patient. These are known as comfort drops, which would contain a mild topical anesthetic, that if somebody had too much pain. I have never done this because I'm scared that they will be overused and misused, and that will lead to corneal complications. Topical NSAIDs have been tried as post-op topical medications for pain control. They've not really been very, very effective. And then the oral analgesics, giving a tablet of, a strong opiate or something like tramadol, which would be good, oral analgesics at the time of surgery. And this does make a difference. And we also give patients tramadol combinations. Non-pharmacological treatments have been tried, bandage contact lens and corneal cooling with chilled PSS and ice patches, and people have used ice packs for post-op pain control. So lots of things have been tried. Even a bolus of oral steroid has been attempted at some places, and even we have done a study on that. So these are the kind of patches, ice packs, which can be used for pain control post-op. They do work quite well, and there's nothing wrong in using them. And we've, there've been a lot of studies, but some of the studies have said that they actually don't make much of a difference. So this study concluded that chilled BSS and the BCL do not seem to be superior to room temperature in reducing post-PRK pain, but subjectively, some patients feel that it makes some difference to them. So our experience with this surgery has been good, and we've had these new techniques where BCL has been used. Our experience with using the BCL, of course, has been good, and BCL helps in reepithelialization and healing to improve the comfort and reduce pain, and can act as a reservoir. So last few years we've been using ketorolac 0.45%, which used to come as AccuVail ketorolac drops, and unfortunately about 2 years back AccuVail was withdrawn from the Indian market. Now this used to, soaking the bandage contact lens in ketorolac had made a world of difference. This pioneering work was done by Rohit Shetty and group at Narayan Nethralaya, and they published on this when they evaluated the efficacy of using AccuVail 0.45% ketorolac on pain modulation. And I started using this around the same time that they were publishing this, after understanding that it really works well. And in fact, I was able to confirm their findings, and we also started doing our own studies on this. So our experience, last 1 year we've been using, in fact, we did the initial trials for this new drug, which is also 0.4% ketorolac. I have no financial interest, but I did perform about 25 patients in the first group of patients, which was studied for pain control using AccuSate, which is easily available now in India. It's because for a few months when we were out of AccuVail, we were trying to convince our Indian companies, the good companies, to start making the same drug if they could. So this comes in unims, and it's been really, really effective. So our first 25 patients showed excellent results, almost similar to or even better than what we were getting with AccuVail. And now we have experience of almost 60 to 70 patients over the last year or so with PRK pain control using this. Let me show you how it works. So basically we use a BCL, and on the BCL, it's peeled, but you throw out some of the fluid from the peeled BSS from the contact lens pack, and then put a few drops. So the Narayan Nethralaya study actually wanted to do this for 30 minutes or 1 hour. We have only done it for, so there we are throwing away some of the fluid from that, and once that is done, we are putting it back there and putting a few drops of AccuSate. And I only like to soak it when I start the case, which means about 5 minutes. So by the time my ablation is over, the soakage is enough and the pain control is extremely good. If you would like to soak it longer, you are free to do that. But since it is accomplished with just about 5 minutes of soaking, so I don't see any reason why we need to soak it much longer. Now, once my ablation is complete, I would wash the cornea with chilled BSS for a while, and then use mitomycin. And then I would wash the mitomycin, and then place the BCL soaked in AccuSate, and this helps for the first 24 hours, after which the patients are, as it is, fairly comfortable. So let's see how it helps. Some of the other important steps: chilled BSS irrigation right after the ablation, and mitomycin C application. So if I'm ablating very small ablations, say 10 to 15 microns, I may elect not to use mitomycin, although my thought is now that we should. And if I'm ablating anywhere up to 50 microns, I would use 0.02% for 12 seconds, and that seems to work very well for me. There are obviously different protocols that other centers follow. For example, LV Prasad follows 10 seconds for each diopter of ablation. I am comfortable doing this, but if I'm ablating more than 50 microns and up to my upper limit for ablation is about 100 microns, if the corneal thickness permits, I would do it for 30 seconds, also for retreatments. And of course, after that, the bandage contact lens soaked in AccuVail, AccuSate. So this is another one of the. So this is an old video on how I was using the Amoils brush for epithelium removal. And today we, of course, do a lot of trans PRK. I have stopped using alcohol completely for more than 10 years now. And the Amoils brush seems to be within seconds, gives you excellent clearance of the epithelium. Only thing is that you cannot use this on a flap. So if you're doing an enhancement on a post-LASEK patient, you would not want to use the brush because it can disturb the flap, and there you might want to use alcohol or some other technique, or even trans-PRK. So once the ablation is done, I would wash it with chilled BSS, and then dry the bed, and then apply mitomycin. This is of course fast forwarded, so mitomycin can be left for, and then this is a contact lens soaked in Accusade drops, Unims. Today we do trans-PRK on the Wavelight platform. It's also available on the Schwinn platform and a few other platforms as well. And now the new Alcon software called Streamlight is very, very good because it removes a plano powered epithelium. So it's specially made for this purpose. And I think if you're doing trans-PRK, then the most important thing is to be doing epithelium mapping. The epithelium thickness needs to be fed in correctly, because if you have a cornea which is average corneal thickness, epithelium thickness is about 50 microns. But since we have been doing this for years together now, we realize that sometimes, even a 600 cornea would have maybe just about 50 microns of epithelium. And sometimes a 470 cornea would have like 52 or 53 microns. So there are outliers. And if you don't feed your epithelium thickness correctly, you will end up getting a wrong treatment. So if you're planning to do trans-PRK, please don't use an average of 50 microns. It would be important to use an OCT-based system to map your corneal thickness and then decide about the surgery. So epithelium healing is much faster. The post-op pain is much less with trans-PRK, and visual rehabilitation is much smoother, because these patients, you're removing exactly the amount of epithelium which is required, and it's a very good value addition to PRK, and we are finding much and much better use for this. This is Accusade Unims which we are using. Here we can probably see one case of transepithelial PRK. So once you have dried all the excess fluid from the conjunctival fornices, and ensure that the cornea is not left dry. There should be no excess fluid on the cornea, and you should be having a relatively dry conjunctiva, so that no fluid comes into the area for trans-PRK. And your tear film should be intact. If it has dried up, you can do a gentle wipe with a wet sponge, which has been, all the excess fluid has been shaken off. And then you can do a gentle wipe to replenish the corneal layers. And then once tell the patient to look into the fixation light, and then you can start the ablation. It's pretty quick. The epithelium is usually gone within about 25 seconds. You'll probably be able to see it now as the ablation starts, and this is continuously followed by the treatment. So it's the epithelium first which is removed, and then there'll be a beep which will tell you that the epithelium is now gone. And then after that, you'll be able to have the second part of the ablation. Some people would like to stop between the epithelium and the treatment, and others would continue straight. There have been differences of opinion whether this works better or that. So now it is the stroma which is being ablated after the epithelium was removed, and it's over. So it's a touchless technique, frankly, and patients are very impressed, because your eyes actually not even touched by any instrument really. You're just cleaning it and washing it with the BSS and maybe with a sponge. So comfort level, so patients who are very, very hyper or anxious, this works really well, because you're not using any instruments, and if they've seen a video of how it happens, they're very impressed. And then you can obviously, after the chilled BSS, you can dry it with the sponge and then apply mitomycin, and follow that up by the Accusade soaked contact lens. So this is mitomycin, and then after this we will be putting on the bandage contact lens. Different techniques are used for people who want to apply mitomycin. Some people use a small cutout sponge which is kept on the cornea for that time. I like to visibly see and keep replenishing the mitomycin. I don't want mitomycin to come to the limbal stem cells at all. So I'm very careful not to put a soaked sponge on the cornea. I just gently apply on the central part of the ablation where the risk of haze is the highest. I will not allow it to creep to the sides of the cornea. And then adequate wash of the mitomycin. And then, of course, the contact lens can be placed on top. There goes the contact lens. We do loosen the speculum a little bit, because when the speculum is being removed, sometimes the contact lens will pop out. So if the patient squeezes, now the results are tremendous. This is patient post-op day 1. She was operated previous evening at 8 o'clock with a surface ablation. And mostly you'll see eyes which are swollen and maybe watery, photophobic patients who are not able to see much on day 1 morning. but you can just watch.
तो आपको रात को सोने से पहले जब लेजर करा के आप गए थे उसके बाद आंख में रेटिकुलर कितनी हुई? थोड़ी बहुत हुई, ज्यादा गतिज तो नहीं हुई जैसे आपको हमने बताया था। तो पेरेबल का वाटरिंग वगैरह कितनी हुई आंख से? खास वाटरिंग नहीं हुई। पेन कितना हुआ? क्लोज एंड शो फेस आल्सो नियर बाय, कम क्लोज एंड शो फेस बिकॉज़ आईज के आसपास कोई स्वेलिंग वगैरह कुछ नहीं है ना। एंड मॉर्निंग में उठ के आपको ठीक लग रहा था? आईज आराम से खुल गई थी सुबह उठ के? और लगातार ऐसा तो नहीं हुआ कि आईज से रडार शुगर बहुत ज्यादा हुई हो, वाटरिंग होती रही हो, ऐसा कुछ नहीं। अब आप वहां पे पढ़ के दिखाओ सामने चार्ट पे। सेकंड लास्ट लाइन पढ़ लोगे? GSCFE. हाँ, very good. चलो जी।
So I think the visions are pretty good. They are 6.6 or 6.9 even on day 1. Day 2 actually the vision may fall a little bit. Day 2 and day 3 as the epithelium healing starts and the the fusion lines are there, and then by the 5th day they are pretty good, and contact lens can be removed on the 4th or 5th day. We start topical FML right on the table, and it is kept for 6 to 8 weeks, sometimes up to 3 months if I'm doing a bigger ablation, and it's tapered. We put moxifloxacin for 10 days, lubricants and a bolus of vitamin C, and then for 15 days, oral NSAIDs for 2 days or SOS, and strict UV protection. Now, this is the key to prevent haze. UV protective glasses whenever the patient has to be out in sunlight for the first 6 months at least. This is very, very important. So potential ocular adverse effects could be there with NSAIDs. So this is a warning that they can be transient burning, stinging, conjunctival hyperemia, and even SPK, corneal infiltrates, epithelial defects, and corneal melt. So if you're very careful and meticulous with your follow-ups, you can avoid most of these and treat them and pick them up early if you have to. So don't let your PRK patients go away and not come back for a week. And this is very rarely even a corneal melt. But with this particular molecule, with ketorolac, there are no reports or almost none reports for any corneal melts. I think epithelium thickness I've already spoken about. It's important. You can see here that one eye has a 53, one eye has a 56. So you have to tailor your ablation with epithelial PRK to correct the exact amount of epithelium. Here we've done a post-op OCT, and this you can see is a contact lens in place. The epithelium has been removed. And this is a post-op healing pattern where the epithelium is beginning to grow back. So you can see that it's only about 30 to 40 microns. We follow up all our patients on OCT. It really helps us understand post-refractive surgery and post-keratoconus patients, how they respond. There are other indications we've been using Accusaid also for our keratoconus patients for cross-linking, because they also experience some pain at night. So we have done about 11 to 12 eyes so far, and the results have been excellent. We've not seen any complications, and patient comfort has been great. So what are the possible implications of what we just discussed? I think PRK currently is only 5 to 10% of the refractive procedures that we currently do in India, and many refractive surgeons who don't perform PRK at all. And so if pain was sorted out, I think there could be a major shift towards the surface, given that the risks are the lowest with the surface ablations otherwise for ectasia. And the phase of refractive surgery may completely change in the very near future if we were able to switch a lot of surgeons to surface treatments. And with that, I think I'm